Hi everyone, I'm Dr. Lucky Seacon and I'm based in New York City. Today I'm going to be doing an Instagram Live with a fellow REI, a board certified OBGYN and REI named Dr. Oyos at IVF Florida, which is a program that is based in Miami, and we're actually part of the same network of clinics. A while and have wanted to do this live because I feel like there's a lot of patients who travel between Miami and New York, and between the East Coast I think we cover a lot of ground. Hi, how are you?
Hi, how are you? Looking nice to see you.
How was your day?
So far, so good. So far, so good.
What
Just
did you
wrapping
do
up.
today? You were seeing patients?
Yeah, seeing patients, doing a couple procedures, and well,
Yeah,
now here for the live.
I had an insane day because I was working from Toronto last week. That's where I'm from. So I had just a lot to catch up on today. I had a lot of scans and patient consults, but I quickly rushed home so I could try to do my live from home. I'm glad the timing worked out.
Well, it worked out for me too. I was able to leave the office, and now I'm from home for this.
Is your commute really long?
Uh, it really depends on which office I am. So,
Okay. Which offices? Tell us about where you see patients. And I'm sorry about my son. It's like crazy in here.
no, it's good. So basically, I mean, we have several locations throughout South Florida. I mean, we
Okay.
go all the way up to Jensen Beach and all the way south to Coral Gables. And I mainly see patients in Coral Gables and Pembroke Pines, but I also go up to Margate every other weekend when we're on call. I mean, Margate is like our base, and that's
Right.
where we do our retrievals, transfers, and whatnot.
Well, I love Miami. I honestly, part of my retirement plan, this is TMI, is to settle in Miami for at least half the year. That's like living the dream in my mind. So I'm familiar with the territory because I spend a lot of time there whenever I can go, I go. And something I've realized over the years is that traffic is kind of a big challenge,
Mm.
and a lot of people live in different areas. So something I think a lot of people should know about IVF Florida, which I think is fantastic, is how many locations you have and how spread you are throughout the city, which I think is super important for a lot of people who haven't gone through IVF. RMA of New York is like this too, and a lot of people who haven't gone through IVF may not realize how many visits, how much follow-up is required. So to be able to see your doctor who may be based at any of those locations, but then to conveniently go to your monitoring appointment if it's close to work to go to one of the satellite offices. Like, I think it's amazing that you guys have that network.
Yeah, unfortunately, we try to make it easy, and at the end of the day, what's convenient for the patient, that's what's best for them, right? I
Yeah,
mean,
for
I have,
sure. Because you got to fitting IVF into your life is not easy. So this is one of the ways
Mhm.
that we can make it easy.
Yeah, for sure. I mean, I have patients all the way up to Orlando, and
Wow.
yeah, they don't need to come see in Coral Gables. I mean, that would be crazy, right?
Yeah.
So they
And you
just
could do a lot
go.
of virtual stuff as well, right?
Yeah, 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 yeah.
I've sent so many patients to you guys because we have so much, I feel like, travel between New York and Miami, which is why I thought it would be really good to do stuff on Instagram so people are aware, and they can make their lives easier instead of having to get on a flight and travel.
Yeah, that's right. And my Naples patients are also saying that it's very important to mention Naples. Yes, we see all the patients in
Yeah, you're
Naples.
getting tons of shout outs in the comments. You're very
Yeah,
popular.
thank you.
So we asked you guys to send in your questions. And basically we have a bunch that I'm going to be pulling up at random. But please feel free, if you didn't have a chance to put your question in the question box, put it in the comments, and we're going to try to keep it short because we both, I'm sure, have lots of things to do this evening, but don't worry, we're going to definitely do a part two. But let's try to spend the next 30 minutes like rapid fire back and forth, try to get through as many questions as we can. And anything we don't, maybe we'll co-post about things, or we can do another live. So let me just start pulling up. Um, sorry, that's someone else requesting to join. Okay, let's talk about, okay, this is a very specific question, but it just happened to be at the top. Someone wants to know if they have a uterine septum. So maybe we can talk about what a uterine septum is and why we care about them. This person had a uterine septum, had it removed, but still has some residual septum at the top measuring 0.85 millimeters. We can talk about the measurements on ultrasound, and they want to know if you think, obviously this is not medical advice, by the way, this is education, so talk to your doctor, but what your opinion would be about if this was your patient, like would you suggest doing another hysteroscopy to resect? And this is just a theoretical question. This is not personal medical advice.
Yeah, correct. So, you know what? With a distance less than 1 centimeter, I typically wouldn't reoperate. I mean, I feel like, if we think that the consequences of the septum are happening because of the length of it, and the definition is more than 1 centimeter,
right,
then I don't see what are we trying to overcorrect when we've already achieved what will be a normal uterus, quote unquote.
Yes. And every time you do something, there's always a potential risk associated. And while hysteroscopies are very low risk procedures, as you said, if it's less than 1 centimeter, what is the concern? A lot of people have an arcuate uterus where there's a little indentation at the top and it's benign. It's just a benign variant, nothing to do. All right. So that was a great one, an easy one to answer. I'm going to pull up some more questions. Give me 1 second. There was a question earlier about a cryonatural approach versus medicated approach to frozen embryo transfers. Can you kind of just go through what those two protocols are and how you counsel your patients about which one to consider?
Yeah, so for all my patients, as long as it's feasible, I tend to offer both approaches, right? Either the program or the natural cycle, understanding that there's some people that will not be candidates for natural cycle. Let's say if they have premature menopause or things like that. But let's say that you have either an anovulatory patient, so let's say PCOS, or patient that's having regular cycles, then you will offer them both. Right. And I told them that, there's, as of right now, there doesn't seem to be, one is not better than the other.
Right.
They're just different.
Yes.
All right. So, for example, some people, for them, it's really, really important to have control. They want their transfer on a specific date. And we know that we can control that pretty good. I mean, sometimes we can't, but at least I told them that with more than 90%, greater than 90% certainty, we know that this transfer will fall on this date.
Yes.
Right. And they want that. But other people, they just want to avoid shots. And as of right now, we know that for program cycles, which are those medicated cycles, having progesterone oil is what gives a higher chance of pregnancy compared with just vaginal progesterone, right? But some people they just want to avoid that. And maybe for them, having a natural cycle is just a much better option. Right. And in that case, it's just a matter of more frequent visits because that's the disadvantage, and the fact that if we miss ovulation, then we're just going to have to try again, right? But the only potential, and at this point, this is not entirely confirmed, and there's a clinical trial actually going on right now, is that maybe in those natural cycles, there's a lower risk for preeclampsia. Okay? But again, we will know that very soon. But all the studies that have compared chance of pregnancy one over the other, they seem to be equal.
Yeah, there was that big Cochrane review, which compiled all the results of, somewhat well-designed studies that looked, obviously they're checking different patient populations and looking at data, and maybe it's comparing apples to oranges. But I find when you just look at one study versus another, the issue is like any patient can bring you any study to prove anything, right? They can bring you a study that shows that cryonatural has better success rates than medicated, and then another center will publish the opposite is true. I actually walked around at ASRM, our big meeting one year, and I remember seeing different posters with exact conflicting results. But the thing is a lot of these are retrospective studies just looking at what happened in the past. And if a center primarily prefers medicated, then who's doing the cryonatural in that center? Usually people that failed with the medicated approach. So you're not comparing apples to apples. You're comparing two different patient populations and vice versa. I like the way you talk about really offering patients the pros and cons of either approach. And you're absolutely right. Like every patient has a different personality. Some people have a really unpredictable job and they can't come in for a bunch of monitoring visits. And they're like, you know what? I love this approach of doing like 3 visits in the lead up, if that. to the actual embryo transfer, knowing it's going to be on this day, on this afternoon. So I tend to do a lot of medicated, but if I have a patient who has significant blood pressure issues or history of preeclampsia, I talk to them about cryonatural versus medicated. And obviously I tell them I might not be able to do their transfer if it's a cryonatural, but all of my partners are fantastic. So I think it's exactly as you said, just like talking about, a balanced discussion of the pros and cons.
Yeah, and telling that even if we do one or the other for the first one, that doesn't mean that we're committed to it forever. No, if it doesn't
Correct.
work out, then for the second one, we can either repeat it or try the other approach and see how we do.
Right. And it's not necessarily the case that the transfer didn't work because you used the wrong protocol.
Mhm.
I think, don't you feel like sometimes patients put so much stock in the protocol when a lot of them are very similar and have very little differences between them? There's just little nuances that sometimes are hard to convey.
Yeah, and at the end of the day, what we have to remember that is that even though we can tweak one thing here, one thing there, the most important ingredient is being changed.
Right.
So it's a completely different embryo, which with a completely different reproductive
Right.
potential. So that's the biggest tweak that you're doing in your subsequent attempt
Right.
right now, right?
Exactly.
Yeah.
And I should have mentioned this at the beginning of our live, but you're the research director at IVF Florida. So you're someone who's really reading all of the most up-to-date literature and aware of all of the latest and greatest with any new study that's come out, which I think a lot of patients don't realize is really important to have a doctor that talks about the latest research and stays up to date on the literature and really has a clear understanding of what's most cutting edge.
Yeah, that's right. And this is a very fast-moving field. I mean, if you compare what we were doing 5, 10 years ago, it doesn't even get close to what we're doing nowadays.
Yeah.
And I'm sure like in the next 5 years, then we're going to be doing things completely different as we learn. Because
Right.
we're
No, it's
learning. We're a very young field overall.
yeah. Yeah, it's so incredible and inspiring. Okay, we're going to go from incredible and inspiring to maybe a more frivolous, superficial
Mhm.
question about Botox. So I get this question all the time. Is Botox okay? This person said while breastfeeding or trying to conceive, but what do you tell your patients who are going through like an egg retrieval cycle and wanting to do Botox, or in the lead up to transfer Botox versus after the transfer? Like, when does it matter? When do you recommend against? What's your school of thought on
So,
this?
so I tell them they need to live their lives, first of all, right? They cannot control everything, and the least disrupted that we can be, then the better it's going to be, right? We have
Yes.
no evidence that Botox is going to affect the retrieval nor the transfer. So if they want to do Botox at that time, that's fine. Now, once they're pregnant, the current recommendation is just to do not do Botox. So that's when I tell them to hold off. But beforehand, I'm completely fine with it.
Right. My only problem with it is that if a patient has really great results, I can't read their reaction when I'm trying to tell them about their good news because, they're frozen. Okay, that was a terrible joke. That was so bad. Okay, no, but I tell patients the exact same thing. Okay, next question. This is a more serious question. Clomid versus letrozole for long irregular cycles, risks, trade-offs versus continuing to try without ... So someone who has irregular cycles and they come to you and that's the issue that they want to be dealing with, what would be your go-to medication of choice depending on what the diagnosis is or what you think the diagnosis is?
Because that's the thing. Really depends on what the diagnosis is and
Right.
also what their body mass index is as well. But for women with PCOS, I tend to default to letrozole. That'll
Yes.
be my number one. Now, that the person that was asking the question, it seems like she has longer cycles, but maybe she could be ovulating.
Mm-hmm.
So let's say that she's ovulatory, then, I tend to default to just Clomid from the get.
Yeah. Can you give a little bit of background? Because a lot of patients are kind of like, well, how do you choose? I feel like it's rare to say we have some randomized controlled trials like class 1 data that actually has helped to guide us on when to use letrozole, when to use clomid. So if you could just, without having to like do a whole journal club on
Mhm.
that study, I'd love for you to talk a little bit about it.
Yeah, so basically we have one study that that was done several years ago, that for women with PCOS, letrozole seems to be superior from the point of view of pregnancy rates when they're overweight or obese,
Right.
right? So that's when we tend to default to letrozole. Now, when the body mass index is less than 25, then typically clomid and letrozole are equal. But I feel like most people tend to use letrozole in those cases because also if we're doing it for ovulation induction, it tends to provide a more monofollicular response. So you tend to ovulate less eggs, so you have a little bit more control.
Yeah.
Now, when we're dealing with unexplained infertility, again, you can use both, right? But my preference tends to be clomid just because I'm trying to get a little bit more robust response compared to letrozole.
Yeah. Yeah. And I think, like what you said earlier, nothing is written in stone. Sometimes people start with one and switch to the other. Often it's in the direction of clomid to letrozole because clomid typically is associated with more side effects than letrozole. And so sometimes when patients have visual symptoms or they're having mood swings, like we might try letrozole in a subsequent cycle. Or if they have a thin lining, that's another time I might switch to letrozole as well, even if they have unexplained infertility.
Yeah, correct.
Someone asked an interesting question in the comments in real time, so I figured I would throw one in. Embryo was frozen, did not expand enough after thawing, transfer was not successful. Could that have been the cause? Then they asked a follow-up question saying something along the lines of, do you think biopsy after PGT, does this happen? So I want your opinion because I've seen a narrative on social media recently about PGT harming embryos. And people are really worried about this. And I've had some patients, even in their 40s, at 41 and older, where I really think they need PGT, be reluctant and not necessarily want to do a fresh transfer. They just want to freeze their embryos and not do testing. And of course, after counseling, I respect their wishes. But what do you say to patients that are concerned about the biopsy for PGT and how it could impact embryos?
I mean, as far as we know, biopsying the embryos has no impact on the reproductive potential. Now, two biopsies, maybe there are a couple of studies. Again, like you said, there's everything in the literature, but I recall a couple of them that maybe show that once you do two biopsies, then maybe the reproductive potential can be impacted a little bit. So I try to stick to just one. So now, sometimes we can't, right?
Yes. Yeah. That's another whole topic, right? Like people don't realize often when you get the PGT result, it's not black and white, abnormal, normal. There's also these two in between results, indeterminate or inconclusive, which doesn't mean anything bad about your embryo. It's just the DNA didn't amplify and they couldn't make a confident call in one direction or the other. And then the other in between result of mosaic, where there's like a mixture of normal and abnormal cells. So if you have this indeterminate result, we give you the choice. Do you want us to rethaw it, biopsy it, and refreeze it? But it's maybe not even the second biopsy. It's all that additional handling and manipulation of the embryo and exposure in the lab. We found the same when we looked at our data. We saw like a 5% around that type of reduction. But also the patients that are down to their last embryo and double biopsying and transferring them are maybe a different patient population than the patients that maybe did have indeterminate embryos, but they had the option and luxury of multiple embryos to choose from. Those are two different patient populations. So I don't know. It's hard to isolate out whether it's really truly the second biopsy, right?
Yeah, correct. And like you said, there's just so much that we don't know as well, right? It's not all just about genetics, right? It's not all euploid embryos are made the same.
Right. Exactly. That brings me to my next question, actually. Someone said they had two failed embryo transfers. Actually, this person said they had 3 failed embryo transfers. How many PGT tested embryos, euploid embryos, would you transfer at this point? I tend to say like keep transferring one. I don't think putting 2 in makes the chances stronger. And I think with a euploid, you never know. Like you said, any given next embryo could be the one that implants. There's a lot we don't know beyond the PGT testing. But what would you tell this patient if they were like, I failed 3 and I want to put back 2? What's your school of thought?
I would still stick to 1. As long as we have a euploid embryo, I mean, the current recommendations is just to do a single embryo transfer. Right? And at the same time, let's say there's something not ideal about that cycle and it's just not going to go well, then you
Yeah.
could potentially be wasting two embryos instead of the one.
Yes.
Now, years ago, when they did that study about having probability of pregnancy after sequential single euploid embryo transfers, and we found out that after three, the probability of pregnancy is around 92% or so. Okay, so that means that there's still 8% of women that do not get pregnant after three subsequent single euploid embryo transfers. Now, that study was recently expanded to 5, and now that probability is 98%. So again, it's never going to be 100%, but it seems that it keeps increasing every time you do another transfer, because every transfer is completely independent.
Yeah.
I mean, you're changing your main ingredient.
What do you think are, and this is a hard question, and I'll throw in my thoughts as well. If you had to list the things that could be the reasons behind someone failing 3 euploid transfers, like what are the things that you search, the recesses of your mind of like, have we checked this? Or maybe it could be this. And I'm not necessarily saying that there's something to do about it, something to test or a solution, but like, what are potential reasons? Because a lot of times people will come to me and I'm like, but this isn't perfect, and maybe it's this, like a lot of times it's like uterine factor, and even if you've had fibroids removed. So what do you tell patients? What are the things that you think could be going on?
I tell them that there's just a little evidence about these additional factors, such as, for example, looking at the uterus, looking for potential chronic endometritis. Maybe they have endometriosis or adenomyosis that has gone undiagnosed, and we may need to suppress it. But again, like you said, none of those things are perfect.
Yeah. What about hydrosalpinx? Because that's been something I've caught here or there.
Yeah. I mean, at least in my practice, we just tend to do an HSG, within the year before every transfer. If there's hydrosalpinx, then for sure we'll remove them.
Yeah. I think that sometimes it happens where, someone's come to me after having a previous workup. Maybe they already had a saline sonogram. I often will think about doing an HSG because I'm like, even though on ultrasound I don't see the hydrosalpinx, there could be something subtle there. And every once in a while I find something and I'm like, it's worth treating it, because if that's the factor, that's an easy enough thing to treat.
Yeah, because the other thing, embryos are commodities, and they're very, very, very important. You need to give them the best chance possible.
Yeah.
Right. So even though, an HSG can be very uncomfortable or whatnot, I just feel like it's worth the trade-off.
Do you guys do HSGs in your practice?
Yeah. Today I was doing HSG.
Oh, really? Wow, yeah. That's great. That's really wonderful. That's like really convenient for your patients to be able to just do everything there.
Yeah, so we do our own HSGs and whatnot. So that's why I tend to do on my Tuesday afternoons.
That's great. So you were wearing your lead and probably like standing under tons of weight.
Yeah.
I'm sure you're tired. Well, we still have 5 minutes. So I want to get through as many questions, but then I'll let you rest because I know you've had a day. This is kind of in the same vein, and I talked about this in a recent post I put up. Someone said they have unexplained infertility. They're age 35, 36, did not do PGT, going to do a medicated FET. Thoughts? I don't really think that's a specific question, but I wanted to draw out a specific question to talk about with you. When do you typically, I'm going to guess that you probably offer PGT to all your patients because you seem like the type of person that offers all the options and counsels the patient, lets them decide. But how do you guide patients when they're like, do I need PGT? Should I think about PGT?
Yeah, that's a very tough question, right? At the end of the day, I always let them decide, but there's some situations in which I tend to favor PGT. There's some situations in which I do not, and there's some situations which is, again, the gray area. For example, couples, when the woman is younger than 35, I tend to say, listen, PGT is an option. We can do this. However, I do not typically recommend it unless, there are a couple of additional reasons. They're really scared of viable aneuploidy, or they may be interested in sex selection in the future. Then I tend to favor PGTA in those situations to just avoid following biopsy in the future and then refreezing. For women that are older than 38, especially if they have a great ovarian reserve, I definitely favor PGTA, because at that point in time I'm using it as a selection tool. And I would rather have some information beforehand, even though it's not perfect, instead of start transferring one embryo at a time and then only finding out that among the 10 embryos that I got 10 months later, then I have to do this all over again.
Yeah, because at 38, it could be 50-50 according to the data that an embryo is abnormal or normal. What about RPL at any age where all the workup is normal?
I do tend to offer PGTA for RPL.
Yeah.
I mean, I feel like, could that be the reason? We don't know.
Exactly.
I mean, the definition of RPL is so conservative that 2 losses could just be bad luck, right? But if we find a specific reason less than 50% of the cases, so if at least I can control for the most common reason behind a loss, which is chromosomal aneuploidy of the embryo, then at least I'm doing something.
Yeah, I feel like it's isolating yet another factor, because there's nothing more confusing and frustrating for patients to be like, oh, it was probably aneuploid. And, to not have that information as they move forward, making this proactive step to try to help them get on the path to pregnancy faster seems kind of counterintuitive, I should say. Yeah. So yeah, and I tend to do it a lot for patients with unexplained infertility too, because I always say sometimes this uncovers an underlying embryo quality factor, whether it's coming from the egg or a combination of sperm and egg factors.
Yeah. And sometimes I feel like, we do have our averages of euploidy over ages, but maybe there's a group of women that are just, they just have a higher aneuploidy rate despite it being younger.
Yeah, I mean, they could have endo, or they could have PCOS, a subtype where there seems to be an association with egg quality issues. I feel like with certain gynecologic conditions, sometimes there can be an impact on egg quality, but it doesn't necessarily apply to every patient with that condition. So it's just another tool in our toolkit to give us as much information as possible to work with. Yeah,
and now on the opposite side of the situation, let's say you have someone who is 36, 37, diminished ovarian reserve, at most they're going to give us one embryo. Then in that situation, I may tell them that, it could be worth just putting the embryo back. At most, we're going to be wasting, it's not going to be a prolonged period of time. And then we make that decision together. Now, if they want to do embryo banking, then again, that's a completely different situation because we're just going to try and get as many as we can. So it really depends.
Yes.
It really depends.
Yeah, it's individualized, and that's how it should be, right? You want to look at each patient as an individual instead of just lumping them into age categories. You want to do what's right for their case and what their family building goals are and all of that. Here's a hot topic that I get asked about a lot, and I'm planning to do a post on it because there's actually been 2 big studies that have come out about it. Ovarian PRP for diminished ovarian reserve, low AMH, poor egg quality. What do you tell patients? I'm sure they come to you asking about this experimental approach and saying, like, is this something that's going to change the game for me? Should I, do this before I do anything else? And what do you tend to tell them?
That we definitely should not do it before anything else. I mean, I don't think that the evidence is there to support that PRP is going to improve ovarian reserve and or egg quality. I mean, the recent studies that we have didn't really change the outcome. So I just feel like instead of focusing on that, we should focus on doing additional IVF cycles.
Yeah. Thinking big picture, where do you want to invest your effort, your time, your money? You want to use something that's proven. And I think the devil's advocate argument for that is, well, if it could help and it could make a difference, I just want to give myself the best chance. I don't care if it doesn't work, as long as, there's a chance that it could help. I'm willing to try anything. I think a lot of people don't realize that it is invasive. Like, it's similar to doing an egg retrieval, except for an egg retrieval, we actually think that the benefits outweigh the low risk. In this case, it's like putting a needle into the ovary when the data has not shown that it's actually helped to improve live birth rates, right? I think what a lot of people don't realize is they look at the studies and they say, oh, well, people's AMH was measured before and after, and there was a bump. But AMH is produced by all the little cells that line each of those follicles. And yes, if you disrupt follicles, it's possible if you check AMH later, like there's more AMH released into your blood circulation. It might just be like an inflammatory response. We don't know. But at the end of the day, does it change outcomes with IVF and get people closer to a live birth? And right now, the data has not shown that. So I don't think,
And I do think that people focus too much on what their AMH level is, right? Which at the end
Yeah.
of the day, what matters is how you're going to respond to stimulation, but most importantly, are we going to get any good embryos from this? And are we going to be able to not only get you pregnant, but help you have a baby at the end of the day,
Yeah.
right? So if an intervention is just increasing your AMH from 0.2 to 0.3, but it didn't really help me or help you have a baby, then is it really worth it?
Yeah. No, totally. Well, I could talk to you forever, but I feel like our half an hour is up and we have a zillion more questions to answer. So I had so much fun talking to you, and I feel like you and I are so aligned in terms of looking at patients as individuals and not just protocols and patient categories, and also caring about what the data says. Even what you said about Botox really resonated with me. This idea of making sure people are continuing to live their lives, because all too often there's an overly prescriptive, restrictive lifestyle, like cut out dairy, cut out gluten, do this, do that. And this is not a sprint, it's a marathon. And the more restrictions you place on yourself, undue restrictions that are needless, it's going to be harder. And the biggest thing that I think sometimes gets in the way of people getting to their end outcome of a live birth, a healthy child, is often dropout, right? We see people get burnt out all the time.
Yeah.
So
Yeah, I do tell everyone that. I mean, the most likely reason why people do not end up having a baby is because, again, they get tired. They
yeah,
get tired. It's a very time-consuming, intensive process. I mean, and our job is not only to guide you, but also to support you during the process.
92% of patients get there after 3 euploid transfers, which is actually incredible if you think about our predecessors. Even people who taught me during fellowship were telling me about like live birth rates of 5%. And I'm like, I don't know how you did your job. We're very privileged and spoiled that we get to call our patients more often with good news versus bad. And I don't mean to make anyone feel bad that has fallen into that 8%, right? There's obviously a lot of room for improvement and things we need to be looking into. But most people with persistence and time will get there. And if you can just stay in the game, that's the key thing. So I love what you said about, living your life. That's like the best advice ever. And this was such an enjoyable conversation. I hope you'll do it with me again, because we have a lot more questions to get to.
Of course, anytime. Anytime, I'm always available.
Awesome. Well, enjoy the rest of your night, and I'll talk to you soon. Hope to be in Miami soon as well.
Would love to see you once you stop by.
All right. Take care. Bye.
Bye.